Hello, everyone. This is Dr. Kim. It's my great pleasure to be able to share another exciting case with you today. So here we're looking at a reconstructive panoramic radiograph of a male patient in his early 20s. So let's go ahead and take a moment looking at this panoramic radiograph. We see that the patient has full dentition in the maxilla and mandible, and that's kind of expected in someone in this age. We don't expect significant periodontal bone loss. I also note that number 17 and 32 are impacted, and obviously 32, that's mesially angulated, and the proximity of the roots to the mandibular canal is, let's just say, very close, right? We'll have to evaluate this in CBCT to get a better understanding of the spatial relationship. But where I want to draw your attention to is the patient's upper left quadrants. Let's see if I can bring out the contrast a little better. All right, so now you look here. The first thing we notice is the position of tooth number 16. Okay, why is it positioned so far superiorly? What's preventing it from being located right, either being erupted or at the level of the alveolar crest, just like the other one. That's interesting. Not that it can't happen. I've seen some, impacted third molars like that, but also angulation of the impaction, right? Why is it not upright positioned or normally positioned? Why does it look like this is horizontally positioned so that we're looking down the long axis of a tooth, right? That's something we should be mindful of or should be asking ourselves. Also, look at the radial density of the maxillary sinus. Here is very radiolucent, suggesting this sinus is clear and well aerated. However, we look over to the other side, that is radio opaque. Furthermore, we can better appreciate the bony outline of maxillary tuberosity. Yes, we can see it, but it doesn't have that nice, thin, corrugated outline that we see on the right side. We see some radial opacity, but is this really bone or is it not? Also, what about the floor of the maxillary sinus? We see the floor and it seems to be going up, or it at least appears to be located in this direction rather than this. So all of that is very unusual, right? So we can only extract so much information on panoramic radiograph. Now we'll have to look at in the multiplanar reconstruction view. But besides number 16, as best as we can see, we don't see significant, say, displacement of number 14 or 15. I guess someone could make an argument that number 15 may have been displaced mesially, and perhaps that could be true. As far as the root resorption, I think, again, hard to say, but at least we don't see a severe root resorption. Now let's go ahead and take a look at that. Okay, so as we have already identified that from panel that this wasn't positioned upright, tooth number 16 is indeed positioned horizontally. But horizontally in a way that the occlusal plane is facing mesially or medially, excuse me, rather than buccally. Or you could say it's facing palatally as well. So that's very interesting, right? And again, let's look at the axial. The left maxillary sinus is essentially entirely opacified. Not only that, what do you think about the medial wall of the maxillary sinus? Let's look right here. Here's the unaffected side. We can see the wall and then the turbinates, inferior and middle, and then the space. It's called, I think, I'm blanking out right now, but there's a term for this space between meatus, right? You guys should know that, right? The listeners, you should know that, but I can't think right now. But let's look over here. The medial wall is not well visualized. It looks like it's been displaced medially, such that the wall itself is now in contact with the middle meatus, right? Middle turbinates. Middle turbinates. Okay, the space means space is meatus, I think. Yeah, middle meatus. That's what the space refers to. Okay. All right. Okay. Do I think the wall is still intact? It's hard to see, right? I don't see the wall corticate outline, but I would think so. I think it's more of an expansion of the bone rather than a very aggressive lesion that's infiltrating and completely destroying the medial wall. I don't think that's what we're looking at. Also, if you look at the roof of the orbit, or excuse me, roof of the maxillary sinus, or the floor of the orbit, they appear grossly symmetric bilaterally. Now we've had the chance to kind of appreciate its behavior, at least on the walls. Let's see what else we can find. All right. So here's the maxillary tuberosity area, and clearly there is a big osseous defect. It's unclear whether this scan was taken after the biopsy. But clearly the alveolar crest is disrupted. I don't see any density of bone, but rather the socket is filled with the same density that we see in the maxillary sinus. So as far as the root resorption goes, it doesn't seem to have caused any root resorption. And interestingly, if you look at the width of the ridge, right, the buccal plate, it's still intact and we don't see a lot of expansion. And keep in mind, when you have a lesion that extends into the maxillary sinus, because you have little to no path of resistance, it's going to quickly grow and fill the maxillary sinus. And which wall did it expand the most? The one that probably provides the least path of resistance. And in this case, it looks like it's a medial wall. Okay, and there's a mild deviation or displacement of the medial wall. But otherwise, the overall kind of bony architecture of the maxillary structures is maintained. And here's a drum roll, the final diagnosis. Of course, you've already seen the title, but this is an example of odontogenic keratosis that has been histologically already confirmed. So here's an example of OKC. Many OKCs that I see is in the posterior mandible. So this is a good case or interesting case to share with you because it involves the posterior maxilla and maxillary sinus. So there are things that we can learn from this, right? That it can cause displacement of a tooth. In this case, it did. It did cause mild displacement of the medial wall. However, it hasn't caused marked or severe expansion of the ridge. It did not cause any noticeable displacement of the adjacent teeth, number 14 and 15, nor we see root resorption. So those are some features that I wanted to point out and hope you found this interesting. And let's see, is there anything else that I want to share with you that I would like to or need to? I think that's about it. I'm sure there are always more features we can talk about. I even see, I just noticed now that there's a thin kind of internal calcification or septation. Not exactly sure. I would have to look at this more carefully. But but some sort of opacity, opacification along the floor of the sinus. Okay. Well, do we see that here as well? No, do we see? Okay, there is a septation, I think, over on that side. Okay. Is that a septation? I think so. So I don't know exactly. I mean, this could be a septation that may have been perhaps displaced by the OKC. So that's, I think, is a possibility. And knowing how often most patient has some degree of calcification, mucositis and dystrophic calcifications within it, there may have been some pre-existing calcification on the floor, and that may be what we're seeing here. But anyway, the major takeaway point that I want you to see is an example of odontogenic keratocyst extending into the maxillary sinus. Anyway, thank you very much, and I'll see you in the next video. And I always appreciate for your interest in my channel and subscribing this channel. And that is actually one of the main reasons that I decide to come back and make recordings. Thank you again. Bye.